Today, speakers will be discussing about jaundice, its diagnosis, and its treatment. I welcome Dr. Bhupesh Chavda, sir, CEO and Medical Director at UditVidit ENT and Children Hospital, Surat, to introduce our speakers. Sir, please.
Yeah. Good evening, sir. Good evening, friends. Myself, Dr. Bhupesh Chavda. On behalf of Surat doctors, Gujarat doctors, I welcome you on the webinar of Indian Medical Association Headquarters, College of General Practitioner. Today, I am discussing about the jaundice and overview and treatment. For that, we have in our studios Dr. Subhash Nandwani, sir, and Dr. Keyur Bhatt, sir. Both are at Surat. સુરત હોય તો મારી ગુજરાતીની પણ વાત કરવાની જ હોય. સુરત અત્યારે શિયાળો છે એટલે ઊંધિયા માટે, લોચા માટે અને સાથે સાથે પોંકની વાની આના માટે પ્રખ્યાત છે. આપ સૌને સુરત માટે આમંત્રણ છે. For that, we have, first of all, I introduce my first speaker, Dr. Subhash Nandwani, sir. Subhash Nandwani, sir, is the founder of his hospital, Seeds Hospital and Research Center. He has done DM, Gastroenterology, DNB Gastroenterology, and FRCS from the London. Sir is a expert academician for whole South Gujarat and Gujarat. And now you also know him for his talent about this subject. So I welcome all speakers, sir, and I request Dr. Subhash Bhai to start his lecture. Thank you. Dr. Subhash Nandwani, sir.
Thank you, Dr. Chavda, for a nice introduction. So my slide is seen. Is it? Okay, can you see my slide?
No, sir.
No. Is it there? I also slide sharing. Not seen.
Screen share कर देना sir.
जी. Right, are we getting?
Yes.
Yeah.
Are we getting? Okay, fine. Okay, thank you.
Yeah, fine.
So, thank you, Dr. Chavda, for my introduction. Thank you, and thanks for everybody. And we'll directly come to our subject. Today, our topic is jaundice overview and the treatment. So, we'll start with the basic physiology. When we see how the bilirubin is formed, so bilirubin is formed from when RBCs are destroyed, heme is formed, and then from heme unconjugated bilirubin is formed, and then unconjugated bilirubin, which we say indirect bilirubin, which is taken up by the liver in the hepatocytes, and then in the liver this indirect bilirubin is converted to direct bilirubin, that is unconjugated bilirubin to conjugated bilirubin with the help of UGT enzyme. And this bilirubin is excreted into the intestine through bile duct, first in the bile canaliculi and then in the bile duct. So we have three phases. One is pre-hepatic phase, and then we have hepatic phase, and then we have post-hepatic phase. The problem can be it at any level out of these three. So first we'll discuss the causes of hyperbilirubinemia, which is indirect one. So pre-hepatic will be there are various disorders of bilirubin metabolism. In hepatic, various diseases of liver disease, and post-hepatic there is an obstruction in the bile duct. So what are the causes of unconjugated hyperbilirubinemia? The first is increased bilirubin production because of hemolysis, because of multiple blood transfusions, or trauma. Trauma because even the muscle injury also will lead to high bilirubin formation, because myoglobin also will lead to the heme, and then the more bilirubin production. So that is about hemolysis. The second step is decreased conjugation. We saw the UGT enzyme. We saw this level, the second level, the hepatic. The UGT enzyme is in some of the patients, around 3 to 4% of population, UGT activity is less than these people present with the Gilbert syndrome, and they have always indirect hyperbilirubinemia throughout their life, but they are asymptomatic and no treatment is required. And then when this deficiency is more pronounced, then the patient have Krieger-Najjar type 2 syndrome. Very rare condition. We have seen very few patients. I think I have seen only 2 patients in my life. They usually present at between age of 15 and 20, but the life expectancy is not much. The type 1 syndrome is very severe deficiency of UGT1 activity. So they develop symptom in the neonatal age, because in the neonatal age blood-brain barrier is not formed, so the bilirubin reaches the brain, and then kernicterus develops, and the children die in very young age. So that is UGT enzyme activity when it is low. And then there is a physiological jaundice of newborn because it takes some time to develop this activity, and then for initially few weeks the children can have. Now the difference between indirect and direct bilirubin is this is not water soluble. So the children or even adult with the hyperbilirubinemia, which is indirect, the urine will not be yellow because it is not excreted in the urine. Now we come to the hepatic causes of jaundice. Now various causes: hepatitis A, B, C, D, E. Then there may be hepatotoxins like alcohol or drugs. There can be ischemia, hypertension, vascular occlusions. This can be arterial or this can be venous. So very severe hypertension, then there will be arterial supply will be a problem to the liver, and then they can develop ischemic hepatitis. Or when there is a congestion, like in congestive heart failure, then also they can have liver congestion and there is a liver ischemia. Or there is a hepatic venous outflow tract obstruction. There are 3 hepatic veins, right, middle, and left. When more than two or more hepatic veins are blocked, then they develop congestion, and then what we call is a Budd-Chiari syndrome or hepatic venous outflow tract obstruction. So there are various causes of pregnancy-related jaundice. They are unique to pregnancy. We'll discuss that. The autoimmune hepatitis, then metabolic causes, Wilson's and hemochromatosis. Last month I have diagnosed 3 Wilson's. Wilson's is not very common conditions, but sometimes they come in crops. In 1 month, 3 Wilson's, not very usual thing. We don't see so many Wilson's nowadays, but it is just an incident that they were diagnosed. So granulomatous diseases, mycobacteria, lymphoma, drugs, post-operative cholestasis, various bacterial infection anywhere, not in the liver, anywhere. Say even in the pneumonia, say in the leg suppose there is a big abscess and the severe sepsis is there, that also can lead to jaundice. So infection anywhere in body can lead to jaundice. Then malignancy in the liver, which can be primary or there can be secondary. Now come to the post-hepatic jaundice. There can be stones or there can be strictures. The stone in the common bile duct, CBD is a common bile duct. In the gallbladder, if the stone is in the gallbladder, that will not cause jaundice, but the stone in the common bile duct will cause jaundice because of the obstruction to the bile flow. Then the stricture in the common bile duct, which can be malignant, which can be benign. Malignant can be one of the 4, either gallbladder malignancy or can be cholangiocarcinoma, the malignancy of the biliary tract, biliary system, or ampullary carcinoma at the ampulla of Vater, or see a head of pancreas which is compressing the lower common bile duct and causing jaundice. And the stricture can be benign, which may be post-surgical or because of the pancreatitis. Now, Gilbert syndrome, as we have discussed, this is a benign condition. Patient will have indirect bilirubin for whole life. Usually it is remaining in the range of 2 or 3, 2, 3, 4, and patients are mostly asymptomatic except the yellow eyes. They have the complaint that all the relatives are telling his eyes are yellow, and the liver functions are otherwise normal. The ALT, there is no inflammation in the liver, so ALT will be normal, retic count will be normal, and there is no treatment required. Prognosis is very good. They live normal life. The life expectancy is normal, and there is no treatment required in Gilbert syndrome. Now, in Gilbert syndrome, only thing what we have to see, we have to differentiate between the hemolysis and Gilbert syndrome. We should rule out hemolysis first. We can check by reticulocyte count, we check by hemoglobin, we can check by LDH. So once hemolysis is ruled out, then indirect bilirubin is high for long time persistent, then this is Gilbert syndrome. Now, Budd-Chiari syndrome, as we discussed, two or more, if hepatic veins are blocked, then the liver is congested, and then that lead to portal hypertension. So they will present like cirrhosis. So it's very easy to miss that patient as a cirrhosis, but how to differentiate that? Liver will be big here because liver is congested. Liver is congested, so liver will be big, palpable liver, number one. Number two, they have ascites. Then you tap the ascites, they should be high protein ascites. High protein, high SAG. SAG means serum ascites albumin gradient. So if serum ascites albumin gradient is more than 1.1, that suggests portal hypertension. Here there is a portal hypertension. So serum ascites albumin gradient will be more than 1.1. But liver will be enlarged, and this will be high protein ascites more than 2.5 gram protein in the ascitic fluid. So high protein, high SAG is a Budd-Chiari syndrome. So high protein, low SAG, the ascites will be tuberculosis, can be malignancy, can be pancreatitis. So this is a rapid onset of ascites with hepatomegaly and color Doppler, or you can go for CT angiography, mesenteric angiography, which will show the blocked hepatic veins. Now, jaundice in pregnancy is a unique condition. We will be very, careful in jaundice in pregnancy. So first condition, there are few conditions which are unique to pregnancy. The first is hyperemesis gravidarum, where the liver functions will be altered, and there can be intrahepatic cholestasis of pregnancy. There will be acute fatty liver pregnancy, which is very rapid course. Preeclampsia, which is a hypertension and proteinuria. The HELP syndrome. HELP syndrome is H for hemolysis, EL for elevated liver enzymes, and LP for low platelets. And then viral hepatitis. Viral hepatitis A, B, C, D, E can be, and any virus can be a culprit. But hepatitis E in pregnancy, we have to be very careful. In first trimester, mortality is around 2%. Second trimester mortality is 10%. Third trimester mortality is around 20%. So high mortality in viral hepatitis E in pregnancy. So you have to be very careful in pregnant patients when they develop hepatitis E. So gallstones, like in non-pregnant people, and underlying chronic liver disease. But usually the diseases should be mild. In advanced chronic liver disease, they don't become pregnant. They are usually their infertility is there. So jaundice in post-operative patients, they can be multifactorial because of the anesthetic agents, because of hypertension during surgery, multiple blood transfusions, because of the sepsis, or because of parenteral nutrition. Usually, then there was a condition called benign post-operative cholestasis, where ALT is normal, and usually there is a self-limiting condition. Now, just fast revision, there can be prehepatic jaundice, where indirect bilirubin is high, normal ALT. Then we have hepatic jaundice, where acute condition ALT will be very high in thousands. In chronic condition, ALT is not that much high. So differentiating point is, if ALT is more than thousands, so that is favoring acute hepatitis. In post-hepatic jaundice, ALT will not be very high. So say common bile duct is obstructed because of stone or stricture, ALT will never be in thousands. It will be in the range of 100, 200. And alkaline phosphatase will be raised. Now, then sonography or ultrasound, the CT scan can differentiate between the intrahepatic cholestasis and extrahepatic cholestasis. When the common bile duct is dilated, intrahepatic biliary radicals are dilated. That suggests this is a extrahepatic cholestasis. Now, just see the graph. If bilirubin is high, now we see whether it is a direct or is indirect. If it is indirect, it is whether it is a Gilbert syndrome or it is a hemolysis. So check there is a whether the retic count is high or not. If retic count is high, then it's hemolysis. Retic count is normal, so this is a Gilbert. If it is a direct, then see hepatic cause or post-hepatic cause. Hepatic cause is acute, ALT will be very high in thousands. In chronic, ALT will not be that much high. In post-hepatic causes, again ALT will not be that much high. So again, that we discussed, retic count high, hemolysis, retic count normal, look for Gilbert. Now cholestasis, again we discussed, cholestasis means there is a stasis of bile. So bilirubin will be high, but direct bilirubin, which is a water soluble, the urine will be yellow. In indirect bilirubin, it's a not water soluble. So there will be itching and clay stool. So you do the imaging, sonography or CT scan, which shows dilated common bile duct or dilated intrahepatic biliary radicals, IHBR. So if it is dilated, is a posthepatic, extrahepatic, and if it is not dilated, is a intrahepatic cholestasis. Now we come to acute viral hepatitis. It's usually short duration, but history of prodrome may be present. Prodrome means history of fever, nausea, vomiting at the onset of. Say patient has history of jaundice for 20 days, and he says that 20 days back he had fever for 3 days, he had vomiting, but after 3 days fever subsided. Now he has only jaundice. So this history suggests that this is a viral etiology. Again, ALT is very high in acute viral hepatitis. And but the most important test what you have to do is prothrombin time, because prothrombin time is high, that means liver is bad. And prothrombin time is depending on the coagulation factor. Coagulation factor half-life is 6 to 12 hours. So day-to-day basis, in very short, because it will tell you the day-to-day progression of the hepatitis. If the liver is worsening, the prothrombin time will worsen. If liver is improving, prothrombin time will improve very fast, because half-life of coagulation factors is 6 to 12 hours. So treatment is all supportive. Viral hepatitis is all supportive, and there is no specific antiviral what we give. Is the full diet. We say full diet and rest. Rest, not necessarily bed rest. He can move around in the home, and when he's comfortable, he can go to the work or school also. So viral hepatitis can be hepatitis A, B, C, D, E. D will come only with B, so we are not discussing D. So IgM-HAV or IgM-HEV will tell about the waterborne diseases. Hepatitis A and E are waterborne. B and C are the bloodborne. And in acute C, HCV RNA we have to check, because hepatitis, this antibodies, HCV antibody will take around 2.5 to 3 months to develop. So even with the ELISA, latest third generation ELISA method, so initially first 2.5 months, it will be false negative. So if you are thinking of acute C, look for HCV RNA. In immunocompromised patient, you have to look for other viruses like herpes simplex, Epstein-Barr virus, CMV virus. But that is in an immunocompromised patient. In immunocompetent patients, usually they are not a problem. Now come to chronic hepatitis. Chronic hepatitis by definition, cutoff is 6 months. So clinical, see jaundice history, a patient has jaundice for 6 months. So it is a chronic hepatitis. Now biochemical, patient has high ALT for more than 6 months. So it is a chronic hepatitis. Or histological evidence, patient has jaundice only for 15 days, but you do biopsy and biopsy shows fibrosis or biopsy shows cirrhosis. So this is chronic hepatitis. So chronic hepatitis history or biochemistry or histology. So then it is chronic hepatitis. So cutoff is 6 months. Now, chronic hepatitis, usually they are asymptomatic. Chronic hepatitis can be because of non-alcoholic steatohepatitis, can be hepatitis B, can be hepatitis C, can be alcohol. So usually they are asymptomatic most of the time, or they may be having very non-specific symptoms, but that lead to cirrhosis in 5 to 10 years, depending on the etiology. Say hepatitis B will cause cirrhosis in 5 to 10 years. Then hepatitis C and NASH will cause cirrhosis in next 20 years. It will take 20 to 30 years to develop cirrhosis. So it's a very slow disease. Now, once they develop cirrhosis, when they are compensated, they are again asymptomatic. There will be no symptoms. Asymptomatic cirrhosis, you can pick up by CBC. You check the complete blood count and platelets are low. So then you think, yes, there is a cirrhosis, there may be portal hypertension. Look for sonography. If the splenomegaly is there, the signs of portal hypertension are there, then you can say there can be cirrhosis. But they can be totally asymptomatic. But when they have decompensation of 5 things. One is ascites, jaundice, encephalopathy, coagulopathy, and a varicose bleed. So 5 things: ascites, jaundice, encephalopathy, coagulopathy. So one of these 5, when this is called decompensation, and then they present to you. But by that time, it is already damaged, because 90% of liver, when it is it's a damage, till then there are no symptoms. More than 90% is damaged, then they come to you with symptoms. So if you cut off the 90% of liver, they remain asymptomatic. So when they give the donor in the liver during transplant, they usually when the liver from the donor they cut almost 70% of the liver. So etiology, we discussed 4 common etiologies. One is metabolic dysfunction associated fatty liver disease, what we used to call NASH, non-alcoholic steatohepatitis. But the terminology alcohol is now stigma. So that because of that stigma, this terminology changed. Now what we call it, metabolic dysfunction associated fatty liver disease. The second cause is alcohol, hepatitis B, hepatitis C, and autoimmune. The MAFLD is the most common. 60% of cirrhosis all over the world are because of metabolic related diseases. So lab test, CBC, as we discussed, low platelet will give you the clue. Sonography will give you nodular liver, irregular surface, and portal hypertension, portal vein enlarged, ascites, splenomegaly will tell you there is underlying cirrhosis. Now come to gallstones. Gallstones can be asymptomatic. The stones can cause cystic duct colic, can cause the cholecystitis, or when the stone comes to the common bile duct, then it can cause jaundice or can cause CVD colic. Now, this is one picture of this is MRI. This is one showing the one big stone in the gallbladder and one stone in the common bile duct. Now, gallstones, how you investigate? You do sonography. Sonography is the test of choice, but remember, the normal common bile duct size is up to 6 millimeter and up to 60 years. After 60 years, add 1 millimeter for 1 decade. So at the 70 years, 7 millimeter is normal. At 80 years, 8 millimeter is normal. At 90 years, 9 millimeter is normal. So when the size is more than 6 millimeter or intrahepatic biliary radicals are dilated, then you suspect there may be stone in the common bile duct. But which may be seen, which may not be seen. There can be 40% chance of missing the common bile duct stone by sonography, because the lower common bile duct is, the gas in the duodenum. The gas is enemy of sonography. So sonography, the waves cannot traverse the gas, the air in the intestine. So the lower common bile duct stone can be missed. The CT scan is not very good test for the stones because radio resistance can be missed. So very commonly we see the sonography showing a lot of gallbladder stones and CT scan says their gallbladder is normal. So then we have to tell our radiologist that look the gallbladder by sonography. So sonography will tell you stones are there or not. CT scan may miss it. MRCP can be done. It is a non-invasive test, but the gold standard is endosonography. So endosonography is gold standard to look for the common bile duct stones. That is now more and more machines are available all over the India. ERCP we don't use for diagnosis. It's only for therapy. Once we are confirmed that there is a stone in the common bile duct, then only we do ERCP, never for diagnosis. That is not allowed now. Now this is just diagram of endosono. Endosono we have two types, radial and linear. Now most of the centers are using linear endosono, and there is a probe on the endoscopy tip which is used for the detection of the stone in the lower common bile duct. This is the picture of ERCP where this endoscope goes through the mouth and goes through the duodenum, and when there is a stone in the common bile duct, that can be removed, or there is a stricture in the common bile duct, the stent can be placed. So this is the radiography picture of the ERCP. Below there is a scope, and above we are seeing the dilated common bile duct. So this is again the scope and the dilated duct. There is a stone is seen, and this picture is showing how it is removed. The papilla, there is what we do, the cannulation of the papilla from the duodenum, and this is cut with the sphincterotome with the current, and then with the help of basket we remove the stones. So we come to the malignant obstructive jaundice. Now malignant obstructive jaundice are progressive jaundice. They had a firm hepatomegaly. Now cirrhosis also will be firm hepatomegaly. Malignant obstructive jaundice also will be firm hepatomegaly. But the difference will be in cirrhosis there will be splenomegaly, because cirrhosis there is a fibrosis. Fibrosis and loss of architecture is cirrhosis. So there will be firm hepatomegaly. But there is a portal hypertension. So portal hypertension there will be splenomegaly, and there may be other evidence of portal hypertension. There may be ascites, there may be caput medusae, there may be jaundice. So features will be there. But in malignant obstructive jaundice, extrahepatic, there will be bile ductular proliferation leading to firm hepatomegaly, but there will be no portal hypertension. So splenomegaly will not be there. So you can differentiate where this firm hepatomegaly is because of the malignant obstructive jaundice or because of cirrhosis. Then raised alkaline phosphatase will be there, and the imaging will show the mass and the common bile duct and ISBR dilation. But remember, the sonography is not good for pancreas. It may show, it may not show. If you are suspecting there is a extrahepatic biliary malignancy, then go for CT scan. Sonography is good in screening test, but if sonography is not showing there is a dilatation of the common bile duct and mass is not seen, then you go for CT scan to pick up the And then you see whether it is operable or non-operable. If it is operable, send to the surgeon for surgery. And if it is non-operable, we do palliative therapy, stenting. Now, how do you stenting? Stenting is indicated only for two conditions: when there is a cholangitis or itching. If patient says itching is there and is disturbing his quality of life, or there is a cholangitis. Cholangitis means pain, fever, jaundice. So this is a charcot striate: pain, fever, and jaundice. This is a charcot striate, the cholangitis. So if it is cholangitis, then you have to do stenting. If there is no cholangitis and no itching, so you can leave the patient. The jaundice is there, but that is a cosmetic problem. Then you no need to do stenting. So how do stenting? There are two types of stent. One is a plastic stent, and then we have a metal stent. So this plastic stent on the left side, with simple, that is a cheaper stent. The stent cost is around 2,000 rupees. Metal stent cost is around 30,000 rupees. So cost is one factor, but in our patients we can do both depending what is the condition in that particular patient. So these are two types of stenting. So thank you. I think my time is up. So we'll discuss in question answer sessions, or any if there are any questions. Thank you.
Thank you, Subhash Nandwani sir. You elaborate subject lucidly and talking about the whole thing, which we know something more than we know for the subject. सुभाष भाई, आपने जो इलोबरेट किया पूरा जॉन्डिस के बारे में, वो बहुत ही अच्छा था, और हमारे पूरे इंडियन कॉलेज ऑफ जनरल प्रैक्टिशनर डॉक्टर को बहुत ही अच्छा भी लगा. Now we have the second expert, Dr. Keyur Bhatt. He is a gastrosurgeon, HPB surgeon. Keyur Bhatt is an intestinal surgeon in Surat. During practice, his practice is 15 years old. He is the author of Complications in GI and HBB Surgery, a book for GI and HBB surgery related complications for fellow surgeons, resident and surgical consultants. Dr. Bhatt is a record holder with the Limca Book of Record, India Book of Record, as well as with Asia Book of Records in the field of GI surgery. Dr. Keyur Bhatt has more than 25 international and national journals, original research and presentation to his name, along with presentation at various conferences in USA and India. The Bhatt is an honorary reviver with many international journal of surgery from India and USA. Dr. Keyur Bhatt is a founder of Seeds Hospitals and Research Center. He is a founder of South Gujarat Surgeon Society. So now we take over to Dr. Keyur Bhatt for his speech. Dr. Keyur Bhatt.
Thank you. Thank you so much for the kind introduction. And I must thank IMA once again for organizing such a wonderful event and making us part of the event. It's a great initiative by the College of Physicians of IMA to do such a wonderful CME activity across, so that everyone can have learning out of it. So, as Dr. Subhash sir has already discussed quite a few points, we'll be still going ahead with the overview of the obstructive jaundice. That is it is qualified as a surgical obstructive jaundice. So we'll divide our talk of 20 minutes in 10 minutes each part. First part we'll go a little bit of theory, and second part we'll try and go with the whatever practical aspect that as a general practitioner we all face in day-to-day life. So clinical features of obstructive jaundice, we all know there are classical signs of yellow skin and sclera, dark urine and pale stools, which is not found generally in case of a medical jaundice. The associated symptoms are pruritus and abdominal pain. These are the very important highlighting features of obstructive surgical jaundice. Nausea, vomiting, fever, weight loss, malaise can be there in both the varieties of jaundice. we all know that diagnostic approach is very standard, that initially obviously we'll try and take the history, the duration, the associated symptoms, because this is very important. The associated risk factors, patient supposedly had a gallstone in past, or patient was an alcoholic, or patient had a previous episodes of pancreatitis, that they can behave in a different way. Physical examination with the sclera, with jaundice, the abdominal tenderness, or any palpable mass in the right hypochondriac region especially. LFT and CBC is a very important part of tool that we'll discuss later. Imaging, there are three basic imaging studies that can help to diagnose and resolve all the problems of jaundice. Ultrasound, CT scan, and MR, we'll see how they are utilized in particular cases when we discuss the cases. So what are the gross causes for the obstructive jaundice? That most common cause of surgical obstructive jaundice is a gallstone. That is either gallstone itself, or it is gallstone slipping into the CBD and causing a biliary obstruction. Followed by the pancreatic cancer or periampullary cancer, and then the biliary stricture. Either it can be a benign stricture, it can be a post-op stricture, it can be inflammatory stricture, it can be stricture because of the pancreatitis, so on and so forth. And that could be a malignancy of bile duct. It's one of the very rare cause, but yes, still it can cause to obstructive jaundice. And last but not the least is a biliary atresia. Usually it is found in infants, and maybe around at the week 3 to 4 weeks interval, generally it is diagnosed. I just try to make it very much simplified, that we can divide these all causes of obstructive jaundice in three different ways. One is the cause within the lumen of bile duct. That could be some parasites, that could be papillomas, that could be cholangiocarcinoma. However, the yellow part, what we can see over here, is the most important thing, and that is the stone in the bile duct is the most common cause of surgical obstructive jaundice. Second cause is a cause within the wall of bile duct. These are benign strictures or malignant strictures. Malignant is most common than benign. Causes outside the wall of a gallbladder. Bile duct. That can be lymph node. There are many lymph nodes in the porta region. There are many lymph nodes in the HPD ligament. So they can get enlarged due to a primary elsewhere, due to a secondary, or due to a lymphoma. There can be tuberculosis. So they all can lead to obstructive jaundice. There can be any mass in the surrounding tissue. There can be mass in the caudate lobe of liver. There can be a retroperitoneal sarcoma, which can compress the bile duct and lead to obstructive jaundice. There could be a stone in cystic duct or a Mirizi syndrome, which can eventually lead to a bile duct obstruction. And however, the most common cause is the head pancreas malignancy or a periampullary malignancy, which is ultimately compressing the bile duct and causing the obstructive jaundice. Mirizi syndrome, it's a little tricky situation where one can see that half of the stone sometimes is lying in the gallbladder and the half of the stone is lying in the bile duct, and it is causing direct or indirect obstruction. But usually in the Mirizi, the lower bile duct is usually normal. And last but not the least is the biliary atresia, where by born the entire biliary tree is atretic, and patient has hardly any space for excreted bile to go into the alimentary tract. So the management options of all the surgical biliary obstructive jaundice is basically divided into three major divisions. One is endoscopic management, other is a surgical intervention, and third palliative one could be a percutaneous intervention. Complications could be disastrous in all the variety of surgical obstructive jaundice. The cholangitis infection leading to a severe sepsis. It can lead to even death also in many instances. Sepsis and liver damage, if there is a chronic liver failure or chronic biliary obstruction because of the stricture, can lead to secondary biliary cirrhosis, which is the fastest growing and fastest developing cirrhosis of all the varieties of cirrhosis. Patient can have cirrhosis within 6 to 8 months of chronic biliary obstruction. So that also should never be forgotten, that chronic biliary obstruction can lead to a further more damage. Prognosis and outcome, it purely depends on the cause of obstructive jaundice, the timing of intervention or referral, and overall patient health. The surgical prognosis definitely depends on what is the etiology in the form of different malignancy, or it is a stone or a benign disease. But highlight over here is the cause, timing, and overall patient's health. Timely referred is a key for treatment of any variety of surgical obstructive jaundice. So early detection, timely referral, and multidisciplinary approach is the key for treating any surgical obstructive jaundice. So we'll go a little case wise so that I have tried to put a real life scenario in 4 to 5 cases that we will discuss now. That a 65-year male had presented with upper abdominal pain for 2 days. It is associated with the vomiting. Slight discoloration of sclera is seen. However, there is no itching and there is no weight loss. So this is a typical history that we get on our OPD. So investigation of choice is CBC, LFT, USG. My every slide is going to repeat the same investigation of choice. That is a basic and number one investigation of choice for all the patient of jaundice is not the SGPT, is always the full LFT, is always the CBC associated with LFT and ultrasound abdomen. No matter whatsoever suspected symptoms, whether medical jaundice, whether surgical jaundice, always get the ultrasound abdomen. It is always non-invasive. It's very cheap and one must always get it done in every patient of jaundice. So we got the CBC done that suggests that there is a slight elevation of the WBC count. Rest of the thing is normal. The bilirubin is 2.9. OTPTs are within 150, 190 range. Alphos is little elevated. Albumin is fine and GGT is again elevated to a 320 level. So ultrasound was done that suggested a GB distended acute cholecystitis. Upper CBD end is dilated with 8 mm diameter. The ultrasound report says that the CBD at porta, they will always mention CBD at porta. Most of the time they don't see a lower end of CBD because of the bowel gas, and lower end could not be visible. This is a very peculiar and typical ultrasound report that generally we get. So if this is the picture, this particular thing, what is next that should be there in our mind? So do not get the CT scan done. See, he is a elderly male with pain, some jaundice, no itching, counts elevated, gallbladder is having acute cholestasis. There is all the more chance that patient is having a CBD stone. So choice of investigation is MRCP or endoscopic ultrasound. There is no point in getting the CT scan done because the CT scan report will be normal and CT scan will easily miss the lower end CBD stone. So the action plan, best investigation is endoscopic ultrasound that suggested a CBD stone. Choice of treatment, once we confirm that yes, there is a CBD stone either on EUS or USG, the choice of treatment is ERCP followed by laparoscopic cholecystectomy. Again, a lap chole can always be planned. If we have done ERCP today, next day is the best time to do a cholecystectomy unless the patient is having pancreatitis or any other complication. Usually the cholecystectomy can be done on the very next day of ERCP, which is done for the CBD stone. Case 2, a 42-year male presented with a non-specific upper abdominal discomfort. Now we need to identify the symptomatology also very carefully. There is no pain, some discomfort is there. कुछ अच्छा नहीं लग रहा, मजा नहीं आ रहा, हम करीने पेशेंट आपड़ी पास से आवे छे. He had itching at night on his back and lower limbs, mostly for last 4 to 5 days. On examination, we see that there is an icterus in the sclera. 42-year male, young male with itching and jaundice. There has to be an alarm because jaundice with itching is a big thing. So action, once again, it is same CBC, LFT, USG. With the same report, we will be able to bring out the conclusion out of it. So we see that HB is fine, count is normal, platelets are normal, but the bilirubin is high. It is 7.9, almost 8. OTPTs are almost normal, one can say 54-39. Alphos is very high and GGT is very high. Albumin level is fine. So ultrasound is done that suggested over distended GB, but there is no cholecystitis. CBD upper end dilated 12 millimeter in size, but lower end again cannot be visualized due to bowel gas. A very typical ultrasound report. So what next? In this situation, there is no fever, there is no pain, there is no other symptoms, but it is associated with itching. Itching happens because of the tight biliary obstruction that generally happens because of malignancy. So whenever there is a itching, one must always suspect itching with jaundice a malignancy. So for malignancy, the investigation of choice is CT scan rather than even a EUS or MRCP, and never get the ERCP done for obstructive jaundice before getting the cross-sectional CT scan of abdomen. So the CT is done. CT is suggestive of lower end CBD mass in the head of a pancreas, around 3 by 2 centimeter, no vessels involvement. So what next? If we go by book, the best investigation next, if at all we want to prove it, then it is EUS FNA or EUS FNA-B. We can get the MRCP done if the surgeon is willing to get it done after the CT scan is done, because ERCP is practically speaking only and only indicated if the bilirubin level is more than 15 or the patient is there with cholangitis, sepsis, and intractable pruritus. Otherwise, there is no point in getting the ERCP done just for the sake of elevated bilirubin. So final treatment, patient will be benefited with the help of Whipple's pancreatic duodenectomy. The surgery can even be planned usually at our center. We do it at 15 bilirubin without any ERCP intervention if the patient is not in sepsis or cholangitis. Case 3. A 54-year female presented with a pain in upper quadrant. I have taken just an anecdotal name, Basanti Devi's Jha. There is a hint in the name. Weight loss of around 3 kg in last 2 months. Middle-aged female, pain, that's it. 3 kg weight loss, no other symptoms. But yes, it is associated with itching for last 15 days. There is no fever. Same investigations, results are different. Count is okay, but HB is little less. WBC normal, platelet normal, bilirubin is extremely high, 19.2. OTPT near normal, alphos is high, and GGT is very high. So this particular LFT itself suggests that most likely it is a malignant biliary obstruction. Patient is coming from either Uttar Pradesh or Bihar, which is a very common belt for development of gallbladder malignancy. So ultrasound was done, which suggested that gallbladder wall thickening. There is a stone in the 12 millimeter size in the neck of gallbladder, upstream CBD dilatation, lower CBD was not visualized. So one must never get confused, because 8 out of the 10 gallbladder malignancy is associated with the gallbladder stone. So we need to see what is the wall thickening, whether it is eccentric, whether it is uniform, or is it associated with acute cholecystitis or not. So next, again, do not get the ERCP done, get the CT scan done. Now there is a malignancy, get the CT scan done just for the sake of staging, as well as to quantify the level of an infiltration of the mass. So there was a mass in the GB neck, involvement of CBD, porta, RHA, right hepatic artery is involved, segment 4B, 5, segment 8 infiltration is there on the CT scan, gross IHBR dilatation, portal vein is free. This report suggests that this is a locally advanced malignancy. This can easily be missed. Segment 4B5 liver infiltration many a times can be missed on ultrasound. So next is to get an FNA or FNA-B from the mass, because this particular case is not amenable for the surgery. So in this situation, either you get a biopsy from EUS or you can get the biopsy with a percutaneous way. Never get the ERCP done for obstructive jaundice because of very tight obstruction, 19 bilirubin. Sometimes it is involving the hilum. That is going to be a difficult situation. So ERCP should always be done again after consultation of a surgeon. Final treatment in most of the this particular variety of cases will be inoperable carcinoma gallbladder of neck. Palliative chemotherapy after biliary metal stenting works best in this situation, because even if we try and put a plastic stent in a locally advanced gallbladder malignancy, it is going to block in 15 to 20 days. And again, patient will not be having any benefit, because that is the time minimum it will be required for 19 bilirubin to come down before we start any chemotherapy. So at times this will require a upfront metal biliary stenting if it is inoperable on its first go in the CT scan. Case 4, a 28-year female, doctor by herself, coming from Punjab. She is a resident doctor over here in the local medical college, presented with a pain in upper abdomen, radiating to back with fever, nausea for last 3 days. Now you see fever, pain, some back pain, fever, only 3 days history. Young female, no other associated symptoms, no weight loss, no itching, nothing. Again, get the same thing done. Results matter. So the hemoglobin is okay, little less, young female. Counts are high, 18,000. Platelets are okay. Bilirubin is moderate, 4.2. SGOT, SGPT in the range of 150, 200. Again, alphos is also in a mid-range and GGT is not very high. Albumin is 3.8, young female doctor, healthy lady. So ultrasound, over-distended GB, no cholecystitis, multiple stones in the GB, large stone 12 millimeter in the neck of gallbladder. Upper CBD dilated 11 mm, lower CBD because she is a young thin lady, no bowel gas. So a sonologist could see easily the lower CBD could be traced till the ampulla without any stone. There is no sludge, there is no mass. It is purely a mid CBD obstruction. Most likely it is because of the gallbladder neck stone. So don't get the ERCP done. However, choice of investigation, if you want to prove it before, one can go ahead with the MRCP to see or confirm that it is a Mirizi syndrome. If it is a Mirizi, which is suggested by MRCP, the best way to quantify the Mirizi syndrome, followed by ERCP can be done so that the stone can be retrieved. One must remember that Mirizi stones are difficult to be retrieved by ERCP. So whether we should go for ERCP or we can upfront go with the surgery, that is up to a surgeon or a consultant. But a final treatment plan could be ERCP plus minus, depends on the situation, because there was a elevated count fever. So it is better to go ahead with the ERCP followed by laparoscopic cholecystectomy. But if the stone is not removed with ERCP, it's a surgeon's responsibility to take off the stone which is lying halfway down in the CBD as well as from the gallbladder neck. So surgeon's perspective, if I conclude, when to refer: red flag signs, suspected malignancy, itching, painless jaundice, severe pain or painless. Both the situation are mostly going in favor of surgical jaundice. Bile duct obstruction whenever we are suspecting, or in case of cholangitis, when there is a fever, pain, jaundice, hypotension, it is absolutely an emergency. This can happen with the cholangitis or this can happen with the ruptured gallbladder. However, for the chronic strictures, it is non-emergent situation and one can refer at ease. So the conclusion is the obstructive jaundice is a serious condition. Surgical cause are absolutely very important to consider and timely management is very much needed. And as all general practitioner, my senior friends, I always request everyone to recognize the early signs, refer them timely so that one can get the proper outcome out of it. Thank you. Thank you so much.
Hello. Dhananjay.
Extremely thank you, sir. If anybody has any questions, please ask away.
Sir, the first question is, can you say a few words about NASH, non-alcoholic?
Yes, sir. Sir, this NASH is the commonest cause of cirrhosis today in the world because metabolic, it's a time bomb. It's a big problem. Metabolic syndrome is a big problem all over because of the obesity. And now what we call is a metabolic dysfunction associated fatty liver disease. The terminology is changed, but the thing is same. NASH or non-alcoholic fatty liver disease, NAFLD. When this is NASH means non-alcoholic steatohepatitis. Steatosis means fat and hepatitis is inflammation. So what happens there? Usually the patient have central obesity, they are diabetic, and over period of 15, 20, 25 years, they develop cirrhosis. Now, how to handle this patient? How you monitor in your OPD? You check SGPT. If you know, I understand in our general OPD, in general practice or in family practice, we cannot do all the investigations. We just check SGPT. If SGPT is high, that means there is inflammation. And sonography will show you fatty liver. Now, sonography showing fatty liver, SGPT is high, SGPT is ALT, ALT is high, that means inflammation is there. Now, once inflammation is there, and if we allow this inflammation to go on for next 20 years, this will lead to cirrhosis. And this is not a one switch on, switch off phenomenon. This is a very gradual process. So, how to monitor these patients? Very simple thing is you do CBC. Now, if the platelets are coming down, that means fibrosis is setting in. Platelets are very good an indirect marker of liver fibrosis. This is suggesting portal hypertension. So platelets coming, say platelet of 1.7 lakh. See, even the pre-op, say patient is going for, say, bypass surgery, and CBC is showing platelet of 1.7 lakh, 1.6 lakh. So you say, okay, with this is normal range, 1.5 lakh is normal, this is 1.6 lakh. But no, you should suspect whether there is underlying portal hypertension, because if there is portal, you check sonography. So in your OPD, if the fatty liver is there, you can repeat sonography maybe once in few years. You can repeat ALT once in 6 months or once a year. Then you see how much fibrosis is there by CBC. Then you have fibroscan. Now, if fibroscan is one test which can tell you about fibrosis. So up to 5 or 6 we say normal, 6 kilopascal. More than 12 is cirrhosis. More the score is more the fibrosis. So these are the things how to much. But the basic treatment is weight reduction, weight reduction, weight reduction. Nothing else works. We can give vitamin E up to 2 years, but main thing is weight reduction. So I usually don't prescribe anything. Many times I tell them, if I prescribe, you will focus on medicine. Then you will not focus on the first, which is most important thing, which is weight reduction. Because unless they reduce weight, they don't improve. 10% of weight reduction sustained, then that leads to reversal of fibrosis. Even cirrhosis can be reversed. To some extent, it's a reverse. It's a not one way. See, cirrhosis is also, even if they develop, you remove the cause, remove the fat, remove the weight, or in hepatitis or hepatitis C, remove the cause, treat the virus, they are reversed to some extent.
Yes.
Can I ask?
Sir, one question from me.
Can I ask question?
Sir, 1 minute.
Yeah.
What is the importance of prothrombin time in jaundice?
Yes, that is the most
Super.
important test in jaundice. Once, if you ask me, once it is diagnosed, it is patient has jaundice, you know it is acute hepatitis or chronic. The most important, if you ask me only one test, I'll check prothrombin time. Because if prothrombin time is improving, say, I'll give you a simple example in acute viral hepatitis. See, acute viral hepatitis, to start with SGPT, say ALT is 5,000, bilirubin is 5. Now, what happens in these patients? ALT starts coming down from 5,000 to 2,000 to 1,000 to 500 to 50. ALT is continuously coming down. That means patient is improving. The patient is improving means patients will start, appetite starts improving, sleep starts improving. The sleep is improved, appetite is improved, you know ALT is coming down. The second thing, bilirubin may go up. That is not a problem. Bilirubin, although ALT is coming down, bilirubin may start going up. 2, 3, 4, 5, 7, 10. If PT is remaining normal, I am not worried. So check prothrombin time. So if PT is normal, patient is improving. If PT is worsening, patient is worsening. Same thing with cirrhosis. In cirrhosis patient, if PT is normal, see, if you see the MELD score, the prothrombin time is one of the most important tests. So PT you must do in all jaundice patients, compulsory.
By the way, wanted to ask.
Yeah. First of all, before asking a question, I must compliment both the speakers who have done a wonderful job in the time allotted, and I really have learned few things from both of you. Thank you very much. My question is that there is a common scenario of OPD of physician as well as family physicians when the patient comes with a sonography report of a gallstone and he has no symptoms, and many of them have been advised for removal of the gallbladder. So what are your take on which are the patients who really need to undergo cholecystectomy?
Right. So all the patients of gallstone practically do not require cholecystectomy. We always keep them conservatively unless. So there are few exceptions for asymptomatic gallstones also. So if I go very precise, then if the stone's diameter is more than 2 centimeter, there is a very much likelihood that in near future patient is going to have complications. So that is number one thing. Number two thing is that if the patient is coming from the Ganga belt or which is very prone for development of the gallbladder malignancy. Number three is the patient's relative or a first degree, second degree relative who had a gallbladder malignancy. So they have a very high likelihood that they will also, because it's a hereditary malignancy, so they can have a very high chance of development of malignancy. Or last number 4 indication for asymptomatic gallstone is somebody who is going for on and off traveling. We do operate a lot of gallbladder stones, like somebody who is there as a merchant navy or Indian Navy, who are going and sailing for 6 months, 8 months, and they generally don't get the NOC unless we take off the gallbladder. So because suppose acute cholecystitis arises somewhere in the middle of a sea, obviously they have to be deported, and so a lot of cost is associated. So these are the practical 4 indications where even in absence of any acute cholecystitis or gallbladder related direct complications, we offer them surgery. Otherwise, you are absolutely right. For asymptomatic gallstone, just ask them to observe. Absolutely fine.
If they are diabetic and have multiple gallstones,
Even though they can be
fine.
observed.
Thank you. Excellent. Excellent.
Yes.
So, if
sir-
patient is having a hepatitis B and after 2 or 3 months the hepatitis is cured and SBSG is negative, the patient wanted to have this vaccination. Can we give them vaccination?
No, sir, vaccine is not required in these patients because they have developed natural immunity. And you can check it by anti-HBs antibodies. If anti-HBs antibodies are positive, that confirms the patient has a natural antibody. So that is the best thing. So there is no need of giving vaccine.
Sir, in cirrhotic patients, usually presentation is very late in the form of hematemesis or the encephalopathy. So in that case, what are the chances of reversal?
Yes, sir. So I know in a family practice, what I understand. See, if I'm seeing a child for say next 10 years, 15 years, 20 years, 25 years, and he comes to me with the cirrhosis, that is my fault. That means I did not diagnose him early enough to prevent the development of cirrhosis. So what I suggest, because see the cirrhosis, most of when they are compensated, they are asymptomatic. Once they are decompensated, then only they present to you. So either ascites, jaundice, GI bleed, coagulopathy or encephalopathy. So by that time 90% liver is damaged. So how to prevent development of cirrhosis? That is by early detection. So what I do, even patient comes to me with the say headache or gastroesophageal refluxes, I do once SGPT, ALT. So if ALT is high, I have to investigate why ALT is high, whether it is fat, whether it is alcohol, whether it is hepatitis B or hepatitis C. Rarely autoimmune. But these are the 4 common. Autoimmune is less common. But one of these 4. So you check for alcohol, hepatitis B, hepatitis fat. Fatal, you can see the central obesity. You can see from the patient sitting in front of you. Central obesity is there. Ask him to reduce the weight. That is one. Then you check CBC. If platelets are low, that means patient has cirrhosis. And then you get sonography. So unfortunately, they come to you with decompensation, with one of the decompensation. But we want them to present early. But whatever the stage, if we remove the cause, they are reversible to some extent. See, patients say 95% liver is damaged and they are present to you. So you treat hepatitis C. We have done it. Patient coming with trans ascites, deep jaundice. We have treated hepatitis C or hepatitis B. Once you treat the cause, there is a reversal because there is a continuously fibrinolysis. See, there is what is cirrhosis? It is a fibrosis plus loss of architecture. So there is inflammation. See, any chronic inflammation in body anywhere leads to fibrosis.
Lead to the fibrosis.
So whatever the cause may be. So whether it's hepatitis B, C, fat, alcohol, anything. So because chronic fibrosis, chronic injury, chronic inflammation, with inflammation there is a healing with fibrosis. Fibrosis leads to loss of architecture, that leads to cirrhosis. Now you remove the cause, there is a continuously fibrinolysis process going on in the liver. So there is no more fibrosis, fibrinolysis is going on. So if over a period 5 to 10% fibrosis is reversed, I have seen patients with trans ascites and coming to me after 15 years with absolutely asymptomatic state. Once the treatment is there, you treat hepatitis B, you treat hepatitis C, they have become hepatitis C negative. After 15 years, they are totally compensated cirrhosis. So it's not one way, child A to child B to child C. It can be reversed from child C to child A also.
Sir, for hepatitis C, antiviral therapy is possible and it also can be normalized.
Yes.
But for hepatitis B?
Yes, hepatitis B also we have very good. Unfortunately, we cannot cure it at present, but we can suppress it. Say tenofovir is there, which is a drug of choice, and it is very easily, not very costly. Say monthly cost is 700 rupees. So 700 rupees per month, 100%. We don't have found any resistance till now. It is very effective. 700 rupees per month. You can suppress the virus and prevent development of complications.
So for the long time, lifetime rather?
Lifelong.
Okay, thank you, sir.
Sir, can I have one question?
Yes, sir.
Sir, a mild to moderate level high of SGPT, is there any significance? We are doing routine investigation and patient having nothing and SGPT is 70, 80. Is there any significant to your topic or
Yes, sir. Definitely it is significant because what I said, I don't want this person to come to me after 20 years with cirrhosis. So I have to diagnose why SGPT is high, whether it is alcohol, whether it is hepatitis B, whether it is hepatitis C, and whether it is a fat. So it doesn't require much cost. Hepatitis B and C cost maybe 200-300 rupees. We can check it. Alcohol, we can ask the history, and fat we can see. We can see the central obesity. Simple. No, even you don't require a very high-fi investigations, but that has to be brought down. SGPT has to come down. I call them after 6 months. I tell them you have to bring down the weight. Weight reduction is compulsory. SGPT has to come down. If SGPT doesn't come down, this person will come to you with cirrhosis maybe after 15, 20, 30 years.
I think one of the commonest cause of high SGPT is drugs that people are taking off without consulting. Also, they keep on taking the medicines, including the herbal medicines.
Right.
So maybe serial follow-up will decide the trend, and if it is high, it has to be ruled out. I agree. NaSH or MASH now we call it has to be ruled out.
Yes, sir.
Thank you. Yeah.
Yes, sir. You are Dr. Keyur Bhatt, sir, and Dr. Subhash Nandwani, sir. You are a pure gems of Surat, and our coordinator, sir, Dr. Dhananjay, sir, and Dr. Darbar, sir, Dhiren, sir. Thank you for giving
Sir,
us
our mentor Madhav
opportunity.
Bhai also.
Our mentor Madhav Bhai, sir, also here. Sir, it is our proud, sir, rather than to see. Whereas, thank you for that. You give us a good opportunity for webinar. This webinar is very much helpful to our general physicians for their practice. Thank you, sir.
Yes.
So, every month on the 4th of this Thursday, we are doing webinar from 4 to 5 p.m. Next will be probably on 23rd January, 4 to 5 p.m. Topic will be and everything banner will be sent to you later on. So we conclude this session. Thank you all.